Alright, now we're going to discuss brain tumors. And so the first question is, what is the most common brain tumor? Now, this is a classic trick question, right? Because the most common is actually any sort of metastatic tumor. And so perhaps the more important question to know the answer to is, what are the common tumors that metastasize to the brain? Well, lung is a major one. That's one you should definitely know. However, you can also see breast cancer, melanoma, lymphoma, renal cell, as well as GI tumors. Now, most primary brain tumors arise from glial cells and thus are known as gliomas. Now, why are virtually all primary brain tumors glial in origin? Well, this is actually sort of simple. It's because the vast majority of neurons in the brain are postmitotic. Cancer is far less likely to happen in cells that aren't dividing at all. Now, other common primary brain tumors include meningiomas, which arise from the meninges, pituitary adenomas, as well as neurofibromas. Now, there are different ways of classifying brain tumors. You can start with whether the tumor primarily presents in children or adults, and then whether the tumor presents in the cerebral cortex, known as supratentorial, or those that present below or infratentorial. The symptoms that the patients present with differ depending on where the tumor is located. Symptoms that should raise suspicion of an underlying tumor include new onset of seizures in a patient who is middle or late age, any sort of focal neurological lesion, headache is a big one, as well as dementia. Now, diagnosis of a brain tumor is typically made either by CT or, as you might have guessed, MRI. Metastatic brain tumors usually appear as multiple lesions in the brain, while primary brain tumors usually only show one mass. Now, as for the different types of brain tumors, I'll mention some of the most salient points, but it's worth spending some time memorizing the different characteristics of these tumors and reviewing their histology. So we'll start with glioblastoma multiforme, because this is the most common primary brain tumor. You can see that on MRI there. Unfortunately, this is also the tumor with the worst prognosis. It is the most advanced grade of astrocytoma. Now, astrocytomas are differentiated based on the degree of differentiation of cells. Grade 1 is the most differentiated, while grade 4 is the worst and it's the least differentiated. Even with our most advanced treatments, fewer than 20% of patients survive 1 year after symptom onset. GBM, or glioblastoma multiforme, is usually found in the cortex, and the classic sign on imaging is that it crosses the corpus callosum. So normally the corpus callosum connects both hemispheres, and you can see here that the tumor basically crosses the corpus callosum. The word multiforme comes from the mottled and heterogeneous appearance of the tumor. Now, its size can lead to areas of necrosis as well as hemorrhages. Histologically, you'll see a lot of cellularity, as you can see here, as well as pseudopalisading pleomorphic cells with nuclear atypia. The pseudopalisading, you can kind of see outlined here. You should also know that glioblastomas on histology will stain for GFAP or GFAP. These will be GFAP positive cells, and that happens because this is a marker for astrocytes, and this is a type of astrocytoma. So these are basically undifferentiated astrocytes. Meningiomas arise from the dura mater of the arachnoid layer. This is an image of a gross specimen demonstrating a meningioma arising from the dura mater, and you can see that here. On imaging, you'll see a circular mass from the meninges compressing the brain parenchyma. They generally favor the falx, which is where it's arising from in this image, and the falx would be somewhere here. Another common place where you will see meningiomas are the meninges overlying the hemispheres, as well as the parasagittal regions. Histologically, meningioma cells are relatively uniform and they form whorls and psammoma bodies. The treatment is with surgical resection. Now, this pathological term, psammoma bodies, shows up in a number of different diseases, but what is it exactly? So here's a picture of a psammoma body. You can see the concentric calcified rings. It is thought to be due to dystrophic calcification, which is certainly seen in a number of different cancers. There is a particular cancer that should have a very strong association in your mind to psammoma bodies. What is this type of cancer? That is papillary thyroid carcinoma. Hemangioblastomas are the rarest of the tumors that arise in the central nervous system. They can occur in many places, but when they are seen, it will usually be in the cerebellum, as seen in this MRI. It is characterized by lipid inclusions, which you can see here with the red staining. This usually happens amid delicate capillaries with intervening large cells with foamy cytoplasm. If we break down the term hemangioblastoma, we have hemangio, which refers to blood vessels. Then we have blast, which is basically referring to undifferentiated cells. And lastly, we have oma, which means mass. So the main thing to remember is that they are commonly associated with von Hippel-Lindau disease. Now, what other tumors did we mention that are associated with VHL? You should remember these are retinal angiomas, renal cell carcinoma, pheochromocytoma, pancreatic cysts, and neuroendocrine tumors. Okay, now let's discuss schwannomas. Remember what Schwann cells do. They myelinate peripheral nerves. A tumor arising from these cells is called a schwannoma. The most common schwannoma arises from the vestibulocochlear nerve, cranial nerve 8. These tumors are sometimes called acoustic neuromas because they extend into the acoustic meatuses. But the term is actually a misnomer, as it's not really a neuroma, but a schwannoma. Recall that these patients may present with central vertigo, and if the tumors are bilateral, as seen in this MRI, then it is highly suggestive of what disease? Now we went over this. You should remember that bilateral schwannomas are a great clue pointing towards neurofibromatosis 2. Oligodendrogliomas are very rare. These are indolent tumors that prefer the frontal as well as temporal lobes. So what do you think this patient will present with? Well, in the temporal lobe, as seen here, you definitely want to think about seizures. In the frontal lobe, think focal hemiparesis. The tumors are often calcified, so you'll see that on a CT. Now, this gross specimen shows a fairly well circumscribed tumor involving the cortex and the white matter. Now, note the hemorrhage and that the tumor does not cross the midline. All of this is the result of hemorrhage. Histologically, the cell has a small round nucleus and a halo of unstained cytoplasm. So some think it looks like a fried egg. Again, we talked about this in terms of looking at oligodendrocytes. And here it's even more pronounced, right? This is your fried egg. I don't eat fried eggs, but I have seen them before, and they look apparently something like that. And you can kind of see that in these cells too. So that's an easy way on histology to be able to tell what type of cell type you're dealing with. Oligodendrogliomas or oligodendrocytes in general should be one that you should be able to pick up. Pituitary adenomas are discussed in more detail in the endocrinology lectures. The thing to remember is that unlike other primary brain tumors which present with symptoms of mass effect, pituitary adenomas are often noticed because of their endocrine symptoms. The MRI shows a heterogeneously enhancing mass in the midline. This expands the sella and extends into the anterior cranial fossa. There is a commonly tested cranial nerve impairment for pituitary adenomas. What is it? Well, you should remember that pituitary sort of intersects with the optic nerve, specifically the optic chiasm. And so you get a defect in the optic chiasm, which results in a bitemporal hemianopia. Now, brain tumors in children most often occur in the posterior fossa. The most common benign brain tumor is a low-grade juvenile pilocytic astrocytoma. The most common malignant brain tumors in children are medulloblastomas and PNETs, or primitive neuroectodermal tumors. Common presenting signs in children are headache, vomiting, papilledema. Now, in infants, they may present with increased head circumference, and that's because the sutures in the skull bones have not actually closed yet. The kids may also present with focal neurological signs and or seizures, just like in adults. Now, certain forms of genetic disorders like neurofibromatosis and tuberous sclerosis are associated with an increased risk of astrocytomas. The only way to know for sure the type of tumor that you're dealing with is to do a biopsy. Pilocytic tumors are typically cystic nodules on radiologic imaging. On biopsy, you'll see bipolar cells with GFAP positive hair-like processes. And so I think you can appreciate that here. Let's find a good example. You can see this bipolarity. And they're very kind of thin processes, which is why they're being referred to as hair-like processes. The tumors may also have so-called Rosenthal fibers, which are swollen pink axons that I'm sure you can appreciate here. Medulloblastomas are highly malignant and carry a poor prognosis. They are, however, very sensitive to radiation therapy, and they are among the class of pediatric tumors called small blue cell tumors. PNETs, or primitive neuroectodermal embryogenic tumors, are a special type of medulloblastoma, and they have a very low degree of differentiation. On biopsy, you can see cells with small hypochromatic nuclei and scant cytoplasm. And I mean, in these cells, you can actually barely even make out the cytoplasm. It looks like all nuclei. You can also see homocyte rosettes, in which tumor cells are concentrically arranged around eosinophilic spaces. Ependymomas are uncommon glial tumors that arise from the ependymal cells lining the ventricles. They are usually slow-growing tumors, most commonly arising in the fourth ventricle. They characteristically show round to oval nuclei and form perivascular pseudorosettes. Let me write that out. Perivascular pseudo, and then I'll just write rosettes down here. Now, if we break this down, we have peri, which means around, vascular, which is referring to obviously the vessel. Pseudo means something appearing like something, but not necessarily that thing. And then rosettes is just describing the shape. You should be able to appreciate that here. Here's your vessel, and here's around the vessel, you have these rosette appearing shapes. Craniopharyngiomas are often confused with pituitary adenoma because they occur in the same area, the sella turcica. They are derived from epithelial cells of Rathke's pouch. Peripheral cells show nuclear palisading. Central cells are loose and termed stellate reticulum. Craniopharyngioma can cause similar symptoms as a pituitary adenoma based on compression of nearby structures. Compression of the optic chiasm again causes bitemporal hemianopia, and compression of the pituitary stalk causes growth abnormalities. Craniopharyngiomas can be distinguished from pituitary adenomas as they often have cysts and calcifications, which are seen on radiologic imaging. Also, you should remember that the hormonal profile is very different. So in pituitary adenoma, you will normally see hypersecretion of some hormone, whereas in craniopharyngioma, there is hyposecretion of hormones. There may be also a mixed hormonal picture. One thing I want you to notice in this histological slide is that, again, you have this pseudopalisading that occurs.